Today I'll be taking a class on allergic rhinitis. Allergic rhinitis is defined as an IgE mediated immunological response of nasal mucosa to airborne allergens associated with sneezing, nasal itching, watery nasal discharge, and nasal obstruction. This may also be associated with symptoms of itching in the eyes, palate, and the pharynx. There are two clinical types of allergic rhinitis: seasonal and perennial. Now, seasonal allergic rhinitis usually presents during a particular season and is when the person is exposed to pollens of a particular plant to which the patient is sensitive. Perennial allergic rhinitis means the symptoms are present throughout the year. There is no race or sex predilection, and allergic rhinitis usually presents in early childhood. Etiology. The most common etiology in allergic rhinitis is exposure to allergens. Now, they may be seasonal or perennial. Seasonal allergens include, as you see in the picture, there is pollen, grasses, and weeds, and it is only during the particular season where the patient develops symptoms of allergic rhinitis. While perennial allergic rhinitis may be due to inhaled or ingested substances, inhaled like house dust, dust mite, animal dander feathers, and ingested due to wheat, eggs, milk, nuts. Other risk factors also contribute to allergic rhinitis, such as genetic susceptibility, family history of atopy, patients having asthma, eczema, hay fever, urticaria, are many of them are prone to allergic rhinitis. Environmental factors like pollution, excessive exposure to tobacco, diesel, exhaust, mosquito repellents are other causes of allergy. Let us discuss the pathogenesis. On inhalation of an allergen, there is production of a specific IgE antibody. Now, this IgE antibody goes and attaches to the mast cell by its Fc end. On subsequent exposure to this allergen, the antigen combines with IgE antibody at its Fab end. Now, this reaction produces degranulation of the mast cells, and there is release of several chemical mediators, some of which already exist in the preformed state, while some others are freshly synthesized. These mediators are responsible for the symptomatology of allergic rhinitis. Now, depending on the tissues involved, they cause different symptomatology. This is the picture which shows the release of mediator substances from the mast cell, which produces the symptoms of nasal allergy. Now, in this picture, you can see the IgE and the drug antigen which binds to the IgE end, and this leads to release of mediators from the mast cell. Clinically, allergic response occurs in two phases: the acute or early phase response and the late or delayed phase. Now, in the acute phase, it occurs immediately within 5 to 30 minutes after exposure to the specific allergen, and it consists of sneezing, rhinorrhea, nasal blockage, and bronchospasm. And this is due to the release of vasoactive amines like histamine. So, histamine is one of the main mediators in the acute or early phase. The late or delayed phase response, it occurs within 2 to 8 hours after antigen exposure, and is caused by the infiltration by inflammatory cells like eosinophils, neutrophils, basophils, monocytes, and CD4 T lymphocytes. It leads to edema, congestion, and thick nasal secretions. In the event of repeated or continuous exposure to the allergen, the acute phase symptomatology overlaps the late phase. This is a chart which shows the release of mediators after an allergic response. Now you can see that when an exposure to an antigen, the mast cells get sensitized and they release the mediators. So there are two types. One is the preformed type, which includes histamine, eosinophilic chemotactic factor of anaphylaxis, neutrophilic chemotactic factor, heparin, and the newly synthesized prostaglandins PGD2, leukotrienes, platelet activating factor, thromboxane A. This is a chart which shows that either on specific allergic stimulus, that is IgE mediated, or any non-specific stimuli like emotional stimuli, response to viral infections, both these can cause release of mediators from the mast cell. And these mediators which are released can lead to symptoms of nasal blockage, bronchospasm, and rhinorrhea. Cardinal symptoms of seasonal nasal allergy are paroxysmal sneezing around 10 to 20 times per episode, associated with nasal obstruction, watery nasal discharge, itching in the nose, the eyes, palate, and pharynx. And these symptoms are very severe during the season. While in perennial allergy, they are not so severe as that of the seasonal type, but they include frequent colds. They can have persistently stuffy nose, loss of smell sensation due to edema of the nose, postnasal drip, chronic cough, hearing impairment due to eustachian tube dysfunction. The signs of allergic rhinitis include in the nose there is a transverse crease. Now, if you see the second picture, you can observe that there is a dark line along the dorsum of the nose, and this is because of constant rubbing of the nose. As you see in the first picture, constant rubbing leads to this crease being formed, and it's also known as allergic salute. Pale and edematous nasal mucosa. Due to allergy, the turbinates become very edematous, and the posterior end of the inferior turbinate becomes edematous and is known as mulberry turbinate. There can be swollen turbinates due to edema, a discharge which can be watery, thin, mucoid type of discharge will be present. Now, the ocular signs are lid edema, Dennis Morgan creases the lower eyelid, as you can see this, allergic shinners, that is very dark discoloration below the lower eyelids, and this is due to venous congestion around the eye. They have cobblestone appearance of the conjunctiva and increased lacrimation. The otologic signs include retracted tympanic membrane or serous otitis media leading to oral fullness, and that is a result of eustachian tube blockage. In the throat on examination, we can see granular pharyngitis, and that is due to hyperplasia of the submucosal lymphoid tissue. A child with perennial allergic rhinitis may even show features of adenoid hyperplasia. In the laryngeal signs include hoarseness of voice and edema of the vocal cords. Diagnosis. Now this ARIA classification, the allergic rhinitis and its impact on asthma classification, is a system of classification which helps in treatment guidelines. Now, when you see this classification, it is based on duration and symptoms of the disease. As you see in the first column, intermittent symptoms, which are less than 4 days per week or less than 4 consecutive weeks per year. So, they are further classified into mild, moderate, or severe. And persistent symptoms are more than 4 days per week and greater than 4 consecutive weeks per year. Now, based on this classification, treatment stratification can be done. To treat any patient of allergic rhinitis, a good history should be taken, physical examination, and specific allergy diagnosis, that is, total and differential count, specific breast test for allergy, nasal smear, skin prick test, nasal allergen challenge test. Now, skin tests. Now, these tests are used to identify the specific allergen. Now, they can be prick test, scratch test, or intradermal test, but the most commonly done is the skin prick test. Now, in this skin prick test, it's an excellent method to demonstrate the allergen. A drop of concentrated allergen solution is placed on the volar surface of the forearm, and a very sharp needle is pricked into the dermis through the drop. Now, this introduces the allergen into the dermis, and a positive reaction is manifested by formation of a wheal and flare reaction and the surrounding zone of erythema flare within 10 to 15 minutes. Simultaneously also we have to perform a control test along with this so as we can see whether there is a similar reaction in the control. This is the picture to show how a single prick is done or a multi prick is done, and this shows the wheal and flare reaction to different allergens. This is a positive skin test which you can see that the wheal diameter is more than 3 millimeter larger than the negative control which is next to it and develops within 15 to 20 minutes. Now the blood test for allergy is total IgE or specific IgE. Now total IgE is rarely helpful as 50% patients have IgE levels within the normal level And specific IgE can be done by radio allergosobent test, that is RAS test. Now in this test, it is an in vitro test. Radio allergosobent test is a very sensitive in vitro test for IgE antibody and measures concentration of antigen by use of antibodies. It helps in identify specific allergens. Nasal allergen challenge or nasal provocation test. It's a gold standard but rarely necessary. In this method, a toothpick is taken with the allergen at its tip and it's placed in the nasal cavity, and the response of the patient is noted. It is mainly indicated when there is a positive history but a negative skin prick test. But nowadays, because of the advent of more sophisticated methods, it is not usually done. Other investigations which can be done is a nasal endoscopy to see whether there is any deviated nasal septum, hypertrophied inferior turbinates, and CT scan of the nose and paranasal sinus to look for any associated nasal polyposis. Treatment can be divided into avoidance of allergen, treatment with drugs, and immunotherapy. Avoidance is the most successful if allergen and antigen is known. Avoid smoking. Known allergens like pollen, food, pets should be avoided if they are known to be causative of allergy. Use of well-fitting masks, especially for people working in polluted areas. Preventing dust mites by use of vacuum cleaner at home and changing the bed sheets every 15 days and washing them with hot water. Pharmacotherapy. Now let us divide into antihistaminics, decongestants, topical steroids or systemic steroids, mast cell stabilizers, anti-IgE, leukotriene receptor antagonists. So let us talk in brief about antihistaminics. So antihistaminics are mainly given as they control rhinorrhea, sneezing, and nasal itch. Now all these antihistaminics may have the side effect of drowsiness to some level or another. Commonly used antihistaminics are cetirizine, loratadine, desloratadine, bilastine. Decongestants. Now, decongestants mainly help in reducing the edema in the nose and nasal congestion. They are alpha adrenergic drugs which constrict the blood vessels and reduce nasal congestion and edema. They can also cause central nervous system stimulation. Certain oral sympathomimetic drugs are pseudoephedrine and phenylephrine. Xylometazine and oxymetazine are usually avoided in allergic rhinitis, but if the patient has very severe nasal obstruction, they can be advised maybe a dose at night. Corticosteroids. Now they can be topical steroids or systemic steroids. Oral corticosteroids are very effective in controlling the symptoms of acute episodes like dexamethasone, methylprednisolone, and topical steroids are given in the form of sprays. Now they can be fluticasone, mometasone. Patient can be used once a day in the morning and it is usually given above 2 years of age. Mast cell stabilizers. Now this stabilizes the mast cells and they prevent them from degranulation even though there is formation of the IgE antigen complex. So mast cell stabilizers are sodium chromoglycate. Now it is available as a 2% solution for nasal drops or sprays or as an aerosol powder. It can be used both in allergic and perennial and seasonal allergic rhinitis. Now, anti-IgE, it reduces the level of IgE and has an anti-inflammatory effect. Omalizumab is such a drug. It is indicated in children above 12 years of age who have moderate to severe asthma. It is not yet approved for only allergic rhinitis. Leukotriene receptor antagonists, they include montelukast, pranucast, and cefalukast. Now they block cystenyl leukotriene type receptors. They are very well tolerated and they have very few side effects. So usually a combination drug of montelukast and cetirizine is given or levocetirizine is given. Immunotherapy is also known as allergy shots or hyposensitization. And the main function of immunotherapy is that it suppresses the formation of IgE antibody. It also raises the titer of specific IgG antibody. Now, immunotherapy is mainly indicated when there is no response to any previous treatment for allergic rhinitis or Due to pharmacotherapy, certain side effects have arisen, like excessive drowsiness, which the patient cannot tolerate. So they are advised immunotherapy. Now, immunotherapy has to be given for a year or so before any improvement of symptoms can be noticed, and it can be continued for 3 years. And after 3 years of uninterrupted treatment, if there is still no response from the patient, then it can be stopped. So you have to wait for some time for immunotherapy for the symptoms to subside. There are two types of immunotherapy: subcutaneous immunotherapy and sublingual immunotherapy. Now, subcutaneous immunotherapy is given below the subcutaneous level, and generally with each visit to the doctor, the dose is increased. In sublingual immunotherapy, drops are given in drops form and it's placed below the tongue. Nowadays, sublingual immunotherapy, or it's also known as SLIT, is being used more frequently, as a dose which can be given as 20 to 100 times greater than that is used by the subcutaneous route.